湾有个家长，对。Professor Gastal and Professor Huang and ladies and gentlemen, welcome to Taiwan Healthcare Quality Association and the ASQua Health Medical Quality Library International Master Webinar Series number 44. Today our focus on quality improvement. Next slide, please. 下一张。I'm Chairman Wei Huang, as Chairman in International Cooperation Community in THQA. Next slide, please. 下一张。This program is organized by Taiwan Healthcare Quality Association. 下一张。And also Asian Society for Quality in Healthcare-ASQua. Next. Now we are welcome our chair, Professor Shao Yuzhen, as a president in Taiwan Healthcare Quality Association for opening. Professor Zheng, please.
Good evening, everyone. I am a president of Taiwan Healthcare Qualities. On behalf of the Taiwan Healthcare Quality Association, I'm very happy to welcome everyone to this evening conference. I'm also very pleased that our association has invited two healthcare quality experts to share their experience and excellent insights. One is the Brazilian expert, Dr. Fabio Leite Gastal, MD PhD, the president of the board of the ONA, the Brazilian National Accreditation Organization, Dean of the UNMED Universities. The topic he will bring us tonight is quality improvements. And another speak were given by the Linkou Changge Memorial Hospital Director of the Quality Management Center, Dr. Huang景泰Professor, to share us with the application of the novel intelligent system to improve the centralized care quality in the hospitalization patient. We know the quality improvement in the Brazilian healthcare systems has been a significant focus over the past few decades, driven by the need to address the challenges such as accessibility, efficiencies, and equalities. The Brazilian healthcare system, known as the Sistema Unicode Decentral, so-called SUS, provide universal healthcare coverages, and there has been various efforts to improve quality across the different levels of care. And Linkou Changge Memorial Hospital has demonstrated a stronger commitment to the quality improvement across the various domains, from the patient safety and the advanced technologies to integrate care and sustainability. These efforts reflect the hospital dedicated to providing high-quality patient-centered care and maintaining its position as a leader in Taiwan healthcare systems. I hope you all can fully enjoy the evening meeting. Finally, I wish everyone peace, health, and happiness. Thank you.
Thank you, Professor Zheng. If any audience have a question, please use the Slido to leave a message to us. Next, Shaidang. This activity is organized by several society in Taiwan. Next, Shaidang. Today we are beginning our International Master Webinar Series. Next, Shaidang. So now we welcome Professor Li Zheng as a president of Kaohsiung National Fenshun Hospital. So, Professor Li, please.
Yes, thank you. Hello, everyone, and good morning to Dr. Fabio, Leite, Gastal. It's my pleasure and honor to introduce our first guest speaker. Dr. Fabio Leite Gastal got his MD degree from Medicine School of Republic University of Uruguay and a PhD degree in psychiatric and medical psychology at the Federal University of São Paulo in Brazil. He got lots of technical and scientific experience in public health, health system and hospital administration, hospital and health service accreditation program, mental health and psychiatry service management. Currently, Dr. Fabio Leite Gastal is the president of the board of ONA, Brazilian National Accreditation Organization. He is also the dean of Unimed University in Brazil. So, ladies and gentlemen, let's welcome Dr. Fabio Leite Gastal.
Hello, my fellows. Thank you very much for your invitation. I'm Fabio Gastal from Brazil, and for me it's an honor to participate in this international meeting with my Taiwanese colleagues. Today I'm presenting for you the Brazilian accreditation experience and the results about that in this evening. I make a briefly resume about the Brazilian history and the context of our health experience and accreditation process. Brazil is a young republic compared by Chinese historical experience, because we make in this year 200 years of our first constitution, independent constitution in our context. We have 7 editions of different constitutions, and now we are in the 7th process of the last constitution from 1988 in the democratic period from our history. We the national health sector is based in these national reforms based on the last constitution, and this is the contextual experience, because this period, 30 years periods, is the context of historical and sociological context to our participation. And the health sector in this period have a real protagonism in this moment of our history. And these reforms beginning in 88 in the last constitution and consolidate in the 90s of last century in these new legislations about health and the creation of national health services similar than the United Kingdom model. The name is SUS, is unique health system in the translation for you. In this context, the health sector creates some different organizations to support the process of the spread the health programs around the country, and very big country because Brazil is a large country, the fifth country in the territorial extension in the world, and this is very complex to create a national health systems in these different regions, and tropical, rainforest, and the south, subtropical, is very different, the sociological context to create these health initiatives. And based on that, we create different structures, and our Brazilian context is a federal country with 27 states, and we have federal autonomy in these different levels to organize our local health services in the municipality. And we have these three levels of governance: municipality, state govern, and federal govern is a national govern in Brazil. And these accreditation programs, the Brazilian National Accreditation Program and Brazilian Accreditation Organization named ONA, is the national organization to support the accreditation program and to create this accreditation network to organize this process in the country. And this process is running in these 25 years and create the movement for quality and patient safety initiatives. And this is in the context of the Brazilian reforms of 19th century and the final of the 20th century in 90s of 20th centuries. And this organization, we named Brazilian accreditation is a Brazilian accreditation system because we need to create a network in that, and this is very complex network to cover all the country and to organize with different institutions, because the Brazilian accreditation system is not governmental or based on state money. Is based on civil society money and civil society organization. Is a voluntary process to educational process and to mobilization of the civil society to improve the health initiatives and patient safety initiatives. And because that, we create this complex network based in funding organizations, associated organizations. The ONA is the Brazilian Organization for Accreditation Programs. The institutions to offer the filed services in the country, the programs to capacitate, to training the evaluators, and to create the providing services for health organizations and health insurance companies, health providing, etc. And today we have the complete certification by ASQua, all the certifications for accreditation standards, accreditation organization, and accreditation surveyor programs, and we are institutional member of ASQua around these last years. And for us, it's we are very happy to knowing you in next international conference in Istanbul, and we are very honored you receive yours in São Paulo next year, 25. And the Brazilian accreditation program in the foundation in 19th century, in 19 years, and 20th century, 1999, when we beginning, we create the public health approach because that, and we recognize Brazil is very complex country, and we have a different levels of quality and capacity to absorb the technology of quality improvement and quality organization, and this is very complex problem because that we create 3 different levels to create a different levels to incorporate the different aspects, different objects of the quality movement. The first level is based on the triad of Donabedian: structure, process, and results. The first level is based to create the health environment for quality and patient safety. The second level is improve the process to create the best practice and the context for good results. And the third level is the recognition of excellence, when the organizations improve the different initiatives and create these aspects to participate in the accreditation program. Today, we have organizations with 23, 24, 25 years directly maintain the certification in the Brazilian accreditation method. Today, we have in this moment around 1,500 organizations accredited in Brazil. We increase 70% every year in these 25 years. We are the third larger accreditation program in the world after the US and Canada, and we have 25 years continuous history, the participation in that, and we recognize in these 25 years more than 5,000 certifications process, and we training more than 50,000 people and health professionals to participate in these cooperative programs and these training programs and the surveyor programs, and this is the process, continual process to training and capacitation. For your vision, this is the Brazilian spread accredited organization in the different states, and we have in Brazil we have some difference. The south and southeast regions is more development, is more urban areas. São Paulo, for example, is in the southeast region, and the different regions have a local difference, and we are spread all around the country in the Amazonic region and South region, and this is very interesting because we create a Brazilian accredited network to health organizations. And this is the graphic expression of the 70% every year increase our results, and our health organizations participate in the accreditation programs to focus in quality and patient safety programs. This is the survey programs. We, in the pandemic process, we need to create a remote survey process, and we validate this process. We create this alternative for our health organizations, and today we have a very good results. The combined methodologies, the hybrid methodologies, remote and face-to-face methodologies to helping the organizations in the big country Brazil, the logistic process of to put the professionals in the very long distance areas is very complex, very expensive, and this remote process, digital process, create an alternative to support these results and this process to create more cheaper and more easy for the people to participate and to presenting their evidence in the accreditation programs. And this is a very complex challenge, because in Brazil, we are a very big country and we have around 380,000 health organizations, and we need to increase more and more to cover all these organizations. But today we are very representative in the hospital accreditation and hospital quality accreditation, because today we have a 71,000 accredited beds, and the principal hospitals in Brazil in the different capital states are accredited by ONA and by Brazilian results. This table presenting the different aspects, the accreditation organizations in Brazil based on different methodologies, and the 90% of the accreditation in Brazil is ONA methodology. The second table, and we presenting the real participation in the different organizations in Brazil. Today we have around 5 century hospitals accredited in Brazil, and the more representative hospitals for the Brazilian community support by health and the different health programs, public health and private health systems. This is a chart for presenting the surveyors capacitation programs. Every year we training the groups, new groups and old groups retraining programs to maintain the quality level of our surveyors training programs, because this is the very relevant aspect to maintain the quality of the surveyor process. And we finished that presenting my institution, because I'm a voluntary. My participation in ONA is I am a president of the board, but I'm a voluntary program because it's a social collaboration for my community. And today I'm a dean of the Unimed University, and because that Unimed participate in the organizations to support the ONA programs, and we participate in the educational programs, consultancy programs to training professionals for spread these methodologies all around our country. And for example, the Unimed University training 170,000 students, professionals, medical, physicians, nurses, etc. We create different post-graduations programs. We create 1,300 programs in the consultancy programs, and we have different undergraduate programs to training the people. And we participate directly in the capacity and the training programs for the different certifications process to spread this best practice in Brazil and in the health systems, because we understand the ONA and the Brazilian accreditation program is very relevant for our community, and we need to increase this process around all the country and all the spaces and different states and municipalities in my country. And this is we supported these organizations to increase their quality and patient safety initiatives. For me, is a very honored to participate in that, and I waiting the Q&A moment to discuss with my colleagues from Taiwan and other countries in the Asia. And for me, thank you very much for your invitation. And for me, is a very honor this participant. Thank you very much and good night.
Okay, we thank you for sharing us the history of Brazil, a beautiful country, and the setup of ONA in your country. So I think it is amazing for you to handle the large ONA group, and also in the meantime, you handle the UNIMED University so successfully. So before we move to a discussion section, would you say some words to people on the website? Thank you.
Thank you very much. And for me, good evening. For me, it's an honor to stay with you, and thank you. And if you have some questions for me, I'm very happy to answer and to contribute with your technical experience, and we share our technical experience tonight. Thank you very much.
Okay, thank you. So we move to the next section, and it will be chaired by Professor Hong Zong Lin. Thank you.
Good night, everybody. It is my honor and pleasure to moderate this section. Next, I would like to introduce Professor Huang景泰. Professor Huang景泰.
院长，我们是要先主持。
对，
我们主持讨论。
哦，先主持讨论哦，我以为是最后才讨论。
对。
Oh, okay.
Discussion.
Sorry.
Yeah, thank you.
Fabio, I'm so sorry that let us open to the if there's no question from the web from line, I would like to invite our participants. First of all, I would like to introduce Dr. Chen from National Taiwan University Hospital. He's the chairman of the Quality Control Center. And Dr. Chen, would you please?
陈世
英主任，嘿。Maybe Dr. Chen is not available now. Let's invite the chairman, Dr. Liu, from Taichung Veteran Hospital. 刘时安主任，嘿。
Oh, okay.
Yes, we are happy to.
Yes,
we are happy to have Professor Gastal to have a very excellent speech for all of us. We have amazing perspective for the Brazilian healthcare system. And I have a question for Professor Gastal. Is there accreditation related to the reimbursement system of Brazilian?
Is a quite different because we are a federal country and we have a different politics in the state's reimbursement process, and in the private sector, the insurance company use the accreditation to reimburse different and more stimulate the quality and patient safety methodologies to pay more, but it's not obligation, it's not a legal issue, it's a voluntary process, because in Brazil we have a very strong licensing system to legalization of the health services based on the state policies and the constitution law, etc. And this is a formal obligation for all health services all around the country by the different states. And the accreditation program is a voluntary expression of the ESG programs to create a new governance, etc. And the insurance private programs or the state programs have freedom to decide put more money or not in the reimbursement process. This is the issue in Brazil.
Okay,
thank you.
Thank you, Professor Castro.
Thank you, Fabio. Next, Dr. Chen from NTUH.
Can you hear me, Professor Lin?
Yeah.
Okay. Yes, thank you. Thank you, Professor Castro, for the wonderful lecture. I have it's actually very enlightening for everyone tonight. And I have one question for Professor Castro. I think in Brazil, when the ONA evaluates the performance of hospital in terms of the quality of care, besides the traditional indicators such as mortality rates, cure rate, complication rate, or patient certification, provided the hospital size. Does ONA also include the performance indicators reported from the patient? I mean the patient-reported outcome measures, such as health-related quality of life, functional status, or symptom elevation, as part of the assessment of the quality care of any healthcare facilities. This is my question. Thank you, Professor.
Thank you very much. I explained in my presentation, we have 3 different levels of accreditation programs, because Brazil is very complex country, and we have different levels in the quality of the offering for the population. And the accreditation program in the 3rd level is a sum process. We create this process. The idea in the 3rd level is obligation to presenting indicators, results of client satisfaction, patient safety results, and continuous results in a long time. This is the idea. And because that we have this steps level to create a quality movement inside the organization and in the community process to mobilize the community. And because that we have a hospitals accreditation, ambulatory care accreditation, home care accreditation, laboratory accreditation, we have standards for the different kinds of organization. Primary care organization, today we have a very strong program in the São Paulo municipality. We have 25 million people in São Paulo, and we have more 400 primary care units in the city of São Paulo. They are accredited, these organizations, and create a movement. And the indicators is very relevant to show for the surveyors the continuity in the process and to make the actualization of the different set of standards in the time, because we beginning 20 years ago, 25 years ago, and the standards make this process to create the new ways of the new priorities of the accreditation, and we have a new experience that. This is, thank you very much. And
Okay.
I'll try to explain.
Okay, thank you. It's great. Thank you.
At last, I would like to invite Professor Guo from National Taiwan University School of Public Health. Dr. Guo, please.
Thank you. It's my pleasure to serve as a panelist in this activity. And thank you again, Dr. Gastal, for the informative talk about the healthcare accreditation system in Brazil. So here I have two questions for you. First, because as you mentioned in your talk, Brazil adopted remote and hybrid survey forms. So how can the surveyors access the evidence related to the quality of care provided to the patients without an on-site visit? I think it is especially crucial because the third level accreditation focuses on culture of continuous improvement in quality. And the second question is, actually, I do a quick search on internet, and it turns out that there are more than 70 healthcare institutions listed on Joint Commission International's website as accredited by them. So I'm curious, why are those organizations in Brazil pursued for being accredited by the Joint Commission International? And from your point of view, what are the significant differences between your accreditation standard and those of the Joint Commission International and other countries? Thank you.
I try to answer both. In the first, we today in the pandemic, we need to create this, to validate this remote alternative to continue the accreditation program, because in the isolation situation, we need to restrict the people in home, and we need to working and to thinking a new alternative. Today, we use the remote process to combine with the face-to-face and field service, because we understand this is a very good alternative for a big country with Brazil, because today we have a lot of costs, of logistic costs based on airfare, tickets, etc., to move the surveyors to distance in the country. And if we use these combined methodologies, we create a best alternative for small organizations for a distant regions in the country, and this is very, very useful. But we use not only one or another. We combine the methodologies to create, because in the third level, we need to evaluate the culture of quality, and it's complex issue, and we need to use the face-to-face visit, etc. And it's not isolated one on another. It's combined today, because this is, I think, in the tragic situation of the pandemic, we learn about that, and we use that. And the second question, today we in Brazil is an open country, and the organizations are free to decide if use the Brazilian methodology or another, US, Canada, etc. But is small. This international methodology is normally used by marketing. Is an expensive, very expensive methodology for Brazilian organizations, and not connected by public health priorities. Is the situation of ONA, because ONA is connected by our national priorities. Is different than Joint Commission or another, is based on marketing strategy of this organization, and is different. We have a very good relation with this institution, but the priority is different, and we have here in Brazil a very peculiar situation. The hospitals, for example, because is the use in this case is in hospitals, the combination, they are beginning the process based on and the Brazilian methodology, and when they are very good results, they are invited international methodology from Canada, from US, to create more public impact, to put in the media, in the TV, etc., to make marketing. We have international recognition. We respect, but if we think in the real results, I not have a completely sure is relevant or not. Is a market strategy. Okay. Thank you very much for your questions.
Thank you.
Thank you, Dr. Gastal. I enjoy your speech very much, and I learned that you already established a very good system of hospital accreditation in Brazil, and you developed the remote accreditation or hybrid method of accreditation. And congratulations. I hope that we can meet you at 2025 in Brazil and to participate in the ASQua in Brazil. Thank you again, Dr. Gastal. Thank you.
And we publish in the ASQua website resumes, newsletters, the study of our remote validation process, our methodology. If you are interested to read about that, is in the ASQua website, our text of our validation process of our remote methodology. Thank you.
Thank you. Thank you.
Thank you so much.
Thank you. Bye-bye.
Bye. Thank you. Bye-bye.
Bye. See you in Brazil. Have a good day.
Thank you.
So next, we will invite Professor Guo Pingzhong, General Counsel in Accredited Hospital in Zhongshan Medical University. So Professor Zhong, please introduce next speaker. Thank you.钟教授，你的没开，声音没开。
Good night, everyone. It's my pleasure to introduce next speaker, Dr. Ching-Tai Huang from Lincoln Chang'an Memorial Hospital. Currently, he is a director of Quality of Management Center. Today, we will talk the title, Application of a Normal Intelligent System to Improve Centralized Care Quality in Hospitalized Patients. Welcome to Professor Huang. Please.
Thank you. Thanks for Professor Zhong's introduction. Today is my honor to have the chance to share our effort to improve the centralized care quality in our hospital with a intelligence system. Actually, we developed this system for quite a few years, and many people here, including Professor Chong and President Lin, actually all have heard about this system maybe many times, but still, because we actually we set up a lot of different intelligence systems and dashboards. Honestly speaking, actually, the majority of them are not actually used by the users we actually proposed to. But for this central line care system, we indeed put it into daily use, try to improve the quality of the central line care in our hospital. So I still would like to share our experience in the past 2 to 3 years, how we perform this, and how actually we learned from the practice, especially the interactions between me and the first line physicians. I think the difficulty for medical quality improvement actually is how we may push forward that actually the first line physicians may listen to us and do something to improve the quality. So I think this would be this central line care system would be a very good example, and we may have some discussions after my short talk. So if there's any difficulties in sharing such a slide, I may share from my side. Okay. Maybe in the slide mode. Okay. So next one. So we all heard artificial intelligence, but I still have to remind, actually, the majority of the AI systems are not indeed AI. So the AI is actually the machine learning, and then the machine may make judgment. But the majority of the intelligence systems we build up actually is BI next. Okay, so BI actually is the intelligence system to facilitate the decision support. Originally in business, so it was called a decision support system. But we use that in clinical application, and then we may name the decision support system as clinical decision support system, CDSS. Next. So ideally, we may build up a dashboard. You may see a lot of information by one site. Maybe not just by one site. You can dig into the next level, or the next level below the next level, to learn all the information you need to make decisions in business or in clinical practice. Next. So we tried this effort since actually 2019, starting from 3 fields, including infectious diseases, emergency medicine, and the pharmacy. So I still remember I actually shared this in early 2020 in Tainan with President Lin and his colleague in Chimay Hospital. And actually, 1 week later, actually, I make a diagnosis of COVID in the patient I cared. So I tested myself, and I was not infected. So if I am infected, actually, President Lin and all his colleagues will be locked at that day. So it's a very a strong memory. I still remember since 2020. So good luck for us. So next one. So this is the dashboard for infectious disease. We have a lot of information from this dashboard, and we can dig into the different panels and to learn a variety of informations like the nosocomial pneumonia, bloodstream infection, multi-drug resistant bacteria, and so on. Actually, and then there's a small part of this is about central line bloodstream infections. Next one. Next. So next. So these are the sub dashboard of the ID dashboard. So my talk today will be centered on the one at the bottom. This is about the central line associated bloodstream infection. Next. So this is the dashboard for our CLA BSI. We have a patient list, and then we have some lights either in red color, green color, or yellow color to show the status of all these parameters. I will go into details later. Next one. So central line associated bloodstream infection is a very important nosocomial infection, and because it is a high cost burden, and actually it is of high incidence, happens almost every day in the hospital, and that is the reason the volume of this problem is high, and we incurred a huge volume every day. So these actually are the numbers from the literature. You can see the numbers are actually indeed very big, and we have to try to take care of this bigger problem. Next one. So central line bloodstream infection, of course, it's a old problem, and we already have a lot of effort try to reduce the incidence of this problem. So the effort was called the CDC bundle. It is a bundle care. That means you have to employ a lot of different measures and to do the best for every single measures of the bundle. Then you can get the best outcome of this care. So for CDC bundle, we pay attention to hand hygiene. We pay attention to full barrier precaution. We use the best antiseptic, and we choose carefully the catheter site, and we force first-line healthcare professionals to do daily review of the necessity of the lines, and we do education from time to time, and the feedback to all the numbers to alert the frontline healthcare workers. You do have problems, and you have to pay attention to the lines, and we make a checklist to make the nurses to check all the items every day, and then we make all these efforts documented. Next one. Next. So So there was a very old paper in New England Journal of Medicine talking about the intervention effort actually indeed may reduce central line associated bloodstream infection in ICUs. Next one. But still, in the bundle, there's no set date for removal. Okay, because this is an invasive procedure. If you set a date for removal and change, actually you may put in the risk of hurting the patient instead of improving the quality of the bundle care. So now it is only required that you have to remove only if the catheter is no longer required, or actually you see signs of infections of the catheters. But at the end, I think we all know, because we are all first-line physicians, basically many central lines are not removed, even there's a very clear signs of infections. Next one. So that is the reason we try to establish this COASQua dashboard. We made a prediction model. So if there is a patient with fever and he has a central line placed for a long time, and there are laboratory signs of infection such as increased CRP, increased white blood cell count, this patient may have a central line bloodstream infection. Next one. So we graded the numbers to assign them a color of light to show how the condition is with the different parameters. So if the central line has been placed for a long time, more than 7 days, it will get a yellow light. If it is more than 14 days, you will get a red light. So CRP, WBC are all likewise. If the numbers are higher, they will get yellow light or even red light. For fever, actually, we focus on the pattern of the fever instead of the absolute value of the body temperature. So if there is a new fever in recent 3 days and no fever at all before 3 days, it will get a red light, because a sudden onset of fever in a patient with a long-term central line catheter, it is possible the fever is due to the line, especially if the WBC and the CRP are high. And if the fever is not a sudden onset in recent 3 days, but instead of in recent 1 week, it will get a yellow light. But if this patient has always fever, then for the fever parameter, the light is green. Next one. So the algorithm actually, the computer system check all patients with fever in our hospital, actually including every campus of Chang'e Memorial Hospital. So President Li, Dr. Li Jiande, actually one day get a call from me. Even he's in Fengshan, southern Taiwan. I noticed one of his patients is very likely has a central line bloodstream infection, and actually, I think that Professor Li actually said thanks to me. I feel very proud of this effort. And all the patients with fever in Chang'e, in all campuses in Chang'e, and they have a central line more than 7 days, CRP more than 30 milligram per liter, and WBC more than 8,000 per microliter, will be put into our dashboard. So again, we put a lot of emphasis on the pattern of fever instead of the magnitude of the fever. So a new fever in 3 days is more alarming, put us on higher alert. This patient is of a bigger problem. Next one. So this is a patient list, and you can see the 4 parameters with different colors of lights. Next one. So in actually daily operation, I will not notice the first-line physicians just because their patients are on the list, because there are a lot of different combinations that the likelihood of central line infection is different. So if a patient with a central line of very long days, such as like 28 days, 21 days, and there's a sudden onset of fever, and the CRP is not only high, but actually is a increasing trend, and also the WBC is not only high and also increases day by day. So this set of parameters will be most likely for to be a central line infection, and we will indeed push the first-line physicians trying to remove or replace the central line. And for the other scenarios listed in this, I will actually look into the patient record and actually make some judgment to decide whether tell the physicians or not to tell the physicians, because indeed, as a medical quality operator, we want to improve the quality, but we do not want to make noises to the physicians, because actually they are indeed very busy. If we keep them bothered by false alarm, I think they will not appreciate, but actually will hate us. Next one. So this is our operation philosophy. The dashboard patient list actually is based on the prediction model I just introduced. So this is a prediction, but not culture-based retrospection. So I think this is not like a lag indicator. Instead of actually, it is based on the prediction. The majority of the physicians, when I reviewed the patient list, the majority of the patients, their physicians actually are not aware of the possibility of the infection. So I also look into the details of the medical records, or not just a alert made by the predictions. And I will communicate with the in-charge physicians in person, not just like a automatic short message alert. So actually, we got 10,000 of such kind of alert every day, and we just dismiss them. Then we will lose the value of this central line alert system. So when I communicate with the in-charge physician, actually, I also provided them with all the clinical details. I actually look into the medical records. So they actually do appreciate I also put the effort in taking care of the patients. So sometimes they misunderstood why I call them up for these patients. Is this patient a very important people? Is a VIP or not? Why you want to look at my patients? No, we look all the patients, they have this possibility, and we try to improve the quality of the central line care. And also, we do not force the physicians to remove the lines. There are many, many reasons they do not want to remove the lines, even they know they are infected, such as in patients with hospice care. They don't want to do any effort. They just want the patient to leave peacefully. So they would rather to leave the lines in place instead of doing another invasive procedure to remove or replace the lines. But ironically, they know the lines are infected. They do not want to remove the lines because of the hospice. But they still use antibiotics very vigorously. So I don't know why. You may remove the lines and you don't have to use the antibiotics. But then they say then the patient will stay in such a very terrible condition for many, many more days, and the family will not be happy with that. I cannot challenge them, but I say I think that then why not you just choke them or actually kill them? That will be faster for the family as well. Why leave a line, infected line in place and use antibiotics for such a long days? But of course, we to understand this prediction model is not a comprehensive coverage for all possibility, for all possible central line bloodstream infection. But on the contrary, we actually reduce false alarms and keep our alert valuable and actually appreciated. Next one. So how is the impact we take this intervention to improve the quality care of the central line? We currently are under a study actually by the medical students during this summer. We try to investigate how our intervention may improve the quality of care of the central line. But in a very gross inspection, we do see that in the recent 1 month or about 1 month, besides Lincoln campus, the biggest campus of all Chang'e Memorial Hospitals, there's none of the alarms happens again in all the other campuses in Chang'e Memorial Hospital. And also in Lincoln Hospital, the frequency of alarm actually becomes less and less. And next one. So we do not have a very clear picture or very definite numbers that how we have improved the quality of care about the central lines. But I think after the introduction, you may all appreciate I do at least save 1 or 2 lives of our patients. But I will try to define all the numbers and parameters to show that actually a intelligence system may indeed improve the quality in this regard. And this is a sentence that I learned from the HIMSS president or HIMSS CEO. He reminded us that AI, I think is BI as well, is a tool and not a goal. I think a lot of us try to do AI or BI, but doing AI and BI become our goal. We do not use BI and AI as a tool, and many people even do not know the goal we do AI or BI. I think for every effort in AI or BI, we may, or actually we should try to define the goal first and then use the appropriate tool in AI or BI to make the medical quality of our institutions better and better to fulfill our purpose of medical quality improvement. Next one. So thank you very much.
Thank you, thank you, Professor Huang, for your excellent speech. Because time limit, we must to remove next session. Next session moderator, President Huang, please.
Professor Lin. Professor Lin Hong.
Oh, Lin. Professor Lin. Sorry.
Okay. Thank you. Professor Huang, I enjoy your speech very much. 3 years ago, 4 years ago, 3 to 4 years, I learned a lot from your innovative system, and we adopted your idea, and we also developed an infection control system for pandemic. And so I was very thankful to you. First of all, I would like to invite Professor Guo from National Taiwan University. Professor Guo.
Yeah, thank you. Thank you, Professor Huang, for your very interesting talk regarding this novel application. So I have one question for you. Is it possible for you to share who could access to this application except for your colleagues from the Quality Management Center? Because we know that other desktop applications on the computers might cover the dashboard. So except contact the physician taking care of the patients, do you have any mechanism to ensure that the clinicians or nurses check the system regularly? Or is there a process to follow up with every patient when the alarm is triggered? Thank you.
So this is a very good question. Actually, I myself, the only person who look at this dashboard every day. So nobody else actually opened this system at all. And then I personally make the communication with the physicians, with the Team Plus system in our hospital. Then we can see whether he has to read the message. I do not push them to answer my message, right? Because they may hate us. They may hate me. I think I just do my job and tell them the possibility. And then the rest of them, whether you want to take an action or not, that's your clinical discretion. So I really appreciate Professor Guo's question, because you know that even the application, the dashboard is very easy to get in just on your computer. I bet the majority, the absolute majority of the healthcare professionals, they did not want to dig into that, because this kind of effort, you get no pay at all. And even for the medical quality center people, so this is also an extra effort. So I think the best way actually maybe we have to prove it, that you use this, you can do something, you can save lives, and people will be convinced it's worth it. You use this application. So this is still the task underway. I'm doing daily until I can get all the numbers to to tell people this actually intelligent system will be useful for you.
Yeah, thank you again, Professor Huang, and so thank you for your effort.
Okay, thank you, Professor Huang and Professor Guo. Next, I would like to invite Chief Liu from Taichung Veteran General Hospital.
Thank you, Professor Huang. Excellent speech. I am amazing by what you did in Chang'e system. I have a question. How many hours do you have to spend in communication with the doctors every day?
Thank you for Dr. Liu's question. So Dr. Liu's question is also very good. I really appreciate, because maybe Dr. Liu want to pay me for the time. So actually, I do not spend too much time in looking at the dashboard. Approximately, actually, like today, actually less than 5 minutes, because there's no alert in the whole system today. But sometimes it may take a lot of time. Maybe there are 5 or 6 alerts I have to communicate with the physicians. But in average, it's less than 10 minutes. So I think it worth my effort, and I am willing to get no pay just for 10 minutes of my time. And for communication with the physicians, I have a template telling all the clinical details. I just copy and change a little bit words, and then send the messages through the Team Plus of our system. So I think I spend less than 20 minutes a day. Of course, weekdays, I do not do that in weekends, because I think this is only an extra effort, and it's not a duty. And the first-line physicians, actually, they should pay attention to their lines by themselves, right? So our effort is not a mandatory thing. Our effort is auxiliary, actually, to try to help. We are not the leading role in this kind of care. So thank you for Dr. Liu. Maybe you will give me a check later.
Yes, good job, good job.
Your time is very valuable, so maybe the check is too big. Next, I would like to invite Dr. Chief Chen from NTUH.
Okay, thank you, Professor Huang's efforts for the safety of the patients with central line. And I have one simple question. I think if my comprehension is right, it's more kind of the CDSS for ID doctor. Then the ID doctor have to discuss with the clinicians or to suggest them to remove the highly possibly infected catheter. Do you have the statistics about how many percentage of these clinical doctors follow your suggestion and remove the catheter, and how many percentage of the patient just leave the catheter inside and just for any kind of reason? Have you ever tried to compare those follow your suggestion, follow the algorithm to remove the catheter, and those patients do not have follow the algorithm and then retain the catheter, infected catheter inside, and if any difference about the outcomes, for example, mortality, length of stay, or any kinds of clinical outcomes. Have you this kind of comparison or this kind of study? Yeah, that's my question.
Okay, thank you for Dr. Chen. This is also a very, very good question. So this is basically this is a study we are doing now with a medical student for this summer. So I think we can divide the patients on the alert system into 4 categories. So one category is that actually I alert the physicians. I made the alert to the physicians. All the rest is not that actually I did not make alert to the physicians. Maybe because I in my vacation in the weekend I cannot make alert to the physicians in time. So I just do not make alert at all. And for the people I made alert, for the patients I made alert, there are 2 categories again, like Dr. Chen said, one category, they remove the catheter as I suggested, or they do not remove. And for the rest of the patients, I do not make alert to them. There are still two categories. One actually is that they do remove the catheters by themselves. I think this is a baseline operation. The physicians, they should do this if they find their patients are possibly with a infected central line. And also there are patients actually with no effort, no movement, no actions. Even the physicians may see or may not see all the signs that the lines has been infected. So the no alert with removal, I don't think we can do any further help for them because they have done very good job. They are very alert. The lines are infected. So all the comparisons Dr. Chen just said, I will compare the alert plus removal to alert plus no removal and the no alert, no removal. I think I may see the impact by this kind of comparison. There's a caveat with all the medical quality improvement intelligence system. You should not get a very significant improvement with the intelligence system, right? If you get a huge, amazing, tremendous impact on the clinical practice, that means your physicians doing nothing. They are bullshit. They are like bullying their patients every day. So I think that's a dilemma. If we introduce a intelligence system and then we try to define the impact of the system, I think we should reduce, actually put apart those the effort the physicians already done very good job. Otherwise, we should nothing, right? So there was a very good example. There was a hospital in Taipei. They have a new intelligence system for emergency room. And after the introduction of the system, the mortality rate of sepsis was reduced from 20% to 33%. So how can their sepsis patients get the mortality of 20% before the intelligence system? I don't think that's possible. So, so we don't say the name of the hospital, but I think we have to understand we cannot make very good, very big impact on the healthcare because I think every physicians are doing their job, trying to giving the best care of their patients. But still, I think there's a room we may improve the quality. I think that's a purpose we tried. Thank you for Dr. Chen's question.
Okay, great. I think we are all expecting the results from your study and to show the effect of the effective and the real-time BI system to help the decision of the clinical management. The reason why I ask this kind of question is that if you can prove the effect of such kinds of the BI system and to prove the effect of the reducing the mortality from early removal of the infected catheter, I think I would like to suggest you should input the BI system such as kind of the automatic notification sent by the BI system to the hospital information system and notify the clinical doctors automatically. So yeah, I think you would be able to save your time and notify the clinical doctors as early as possible once the scoring reach the risk of the infected catheter. This is my suggestion. I'm expecting sometimes you should try to incorporate your BI system, this kind of algorithm to the information system of your hospital. Thank you.
All right, I would like to make an end. So first of all, I would like to thank the panelists, the Dr. Chen Siying, Dr. Liu Sian, and Professor Guo Nianzhen And last, I would like to express my thanks to Professor Huang景泰for his interesting speech. My take-home message is that BI may be enough and colorful. AI is a goal, is a tool, not a goal. Thank you, everybody. Last, I would like to hand over to the Professor Huang, the chair, Professor Huang.
Thank you, Professor Lin, and the expert online. So today we have a very wonderful night. We have a Professor Fabio Gastal from Brazil and also Professor Huang from Taiwan, and so many experts to join tonight the webinar. We hope we can continue to provide the best quality of the medical quality webinar for you. So please follow up our website in ASQua or in THQA. Thank you, everyone. Good night.
Thank you. Have a good night.
Thank you. Good night.
Good night.